Good morning and good afternoon. Welcome to our panel session entitled Addressing Gender Equality and Integrating GBV Across the Clinical Cascade. My name is Erin Scheller. I'm a gender advisor with USAID Washington's Gender and Sexual Diversity Branch, and I will be moderating today's panel. Thank you so much for joining us today. We have 3 great presentations ahead as we highlight new and innovative activities by our local partners addressing gender equality and gender-based violence to help mitigate HIV. First, a couple of housekeeping reminders. Look at the globe at the bottom of your screen for French or Portuguese simultaneous translation. For today's session, participants will be muted, but we strongly encourage the use of the chat box. Please feel free to enter questions and comments throughout the presentations, and we'll have extra time at the end for questions and discussion. As has been well documented, gender inequality and gender-based violence are some of the most critical barriers to reaching HIV epidemic control. Globally, 35% of women experience intimate partner violence or non-partner sexual violence in their lifetime. And women who experience intimate partner violence are 1.5 times more likely to acquire HIV. The experience of GBV is associated with lower use of antiretroviral treatment, half the odds of self-reported ART adherence, and significantly worsened viral suppression among women. Intimate partner violence has also been found to lower adherence to pre-exposure prophylaxis. In short, violence poses a substantial barrier to the effectiveness of HIV services and can undermine the uptake of and adherence to proven biomedical prevention and treatment options. As we heard from Amelia Peltz during yesterday's priority population technical updates, the Biden-Harris administration has made advancing gender equality and equity a priority along with addressing GBV. And we anticipate the forthcoming COP22 guidance will have enhanced emphasis on the cross-cutting nature of GBV prevention, case identification, and response integration into HIV services. Addressing violence and inequality across the HIV cascade is essential to reaching PEPFAR's epidemic control goals. The work our panelists will speak to today spans our strategic priorities. In the same way we address HIV across the clinical cascade, we also address GBV prevention, case identification, and response along the cascade with the goal of improving HIV prevention, testing, and treatment outcomes. USAID's local partners are critical in continuing our technical leadership to advance this work. First, today, we will hear about a Nigerian adaptation of a curriculum-based strategy to prevent sexual violence from Charity Elachukwu. Charity is a gender and adolescent advisor at Center for Clinical Care and Clinical Research in Nigeria. A holder of a bachelor's degree in nursing science, she has 13 years experience in clinical and public health practice with a focus on HIV care, treatment, and support. She's currently pursuing her master's in public health at University of Suffolk. Next, we'll hear an example from Malawi that highlights the importance of GBV prevention, identification, and response among key populations. Liawaka Mwala is a trained community outreach worker now supporting HIV testing services in the PEPFAR-funded Local Endeavors for HIV Prevention and Treatment Project. She previously worked in a similar role in the Linkages Malawi project. She has over 7 years experience working with sex workers at the community and clinical work level. She champions gender issues by passionately supporting vulnerable women experiencing violence in their lives. Our third and final presentation focuses on post-exposure prophylaxis in Kenya. Beatrice Abura holds a master's degree in nursing and has 8 years of professional work experience in health programming and issues including HIV/AIDS, family planning, sexual and reproductive health, nutrition, GBV, and WASH. She mainly works with national health management teams and providing technical leadership and support in health system strengthening, capacity building, and strategic development. Beatrice currently serves as a program officer focused on care and treatment at Ampath Plus. I'm excited for the opportunity to highlight this important work being done to address violence and inequality across the HIV cascade today. And now I will turn it over to Charity for her presentation on I Am Safer, a curriculum-based sexual prevention strategy contributes to reduction in sexual violence in Akwa Ibom, Nigeria. Next slide, please. Thank you.
Thank you, Erin. Hello, everyone. I'm so happy for this opportunity. I'm doing this presentation on behalf of Malawi Center for Clinical Care and Clinical Research, which is implementing the IntraHealth and Social Award, a USAID 5-year award that is implementing in the South region of Nigeria. We'll be showcasing how a curriculum-based sexual prevention strategy contributes to a reduction in sexual violence in Akwa Ibom State. Next slide. So, a little background of the issue. We know that gender-based violence is a public challenge, and the sexual violence has remained a global public health issue. During the COVID-19 lockdown in Nigeria, there was an increased cases of rape across the country. And in Akwa Ibom State, where we work, we recorded 87 cases of rape within 4 months during the lockdown between April and August 2020. And the rape cases cut across all age. And the youngest among the survivors was an 18-month-old baby. A deep dive into the data, we also realized that 3 local governments accounted for over 50% of the reported cases in Akwa Ibom. Next slide. So the pre-planning for the AMSAFA, this is the first time AMSAFA was implemented in Nigeria. And the AMSAFA is an evidence-informed violence prevention curriculum that was designed basically for implementation during COVID pandemic. It was just a modified curriculum version of the evidence-based Empower curriculum. It was due to the COVID-19 that the curriculum was adapted to modify to suit the situation. And it was deeply rooted in empowerment self-defense mechanism for adolescents, which is a survival-centered, feminist approach to self-protection skills. Next slide. So this is our methodology. The AMSAFA curriculum was aimed to increase girls' skills in assertiveness, setting boundary, and as well as boys' gender equitable attitude, and also to help the girls to develop verbal and aptitude skills to defend themselves when they face or witness any assault. For the month of August, what we did was collaborative design and adaptation of the curriculum due to the COVID pandemic, working with our partner, No Means No Worldwide, to adapt the curriculum. And we also used that August to look at our data critically to select the local government where we have GBV burden for the pilot of the AMSAFA program. And we also conducted the community engagement with the community leaders to get their buy-in and also for them to understand the value of AMSAFA program and to get their support. In October 2020, we started profiling and the recruitment of instructors. We used that. The No Means No also provided the eligibility guide of who should be recruited as an instructors. And the instructors were recruited, 16 of them, and they were also made to sign the child safeguarding policy. In November 2020, November and December is when the training started. It was an intensive training that was delivered virtually, and the 16 instructors were certified to start facilitation of AMSAFA curriculum among the adolescents. So they worked in pair, they paid instructors, and we also came up with a field deployment plan for them to move to the community and the field. From January to June, the instructors commenced formation and facilitation of sexual violence sections with adolescent cohorts. They were also trained online on how to manage disclosure in case any of the adolescent disclosure of any experience of sexual violence. And then due to COVID, the initial plan was for them to, a cohort should be made up of 40 participants, but due to COVID, the maximum was 20 participants per cohort to ensure that social distancing was also maintained. So within the February and June, we started the mentoring and follow-up of the instructors to review what they have done and also to get a feedback or to evaluate the impact of the program. And also, we also did like a tracer study of those adolescents who had completed the session. We conducted a focus group discussion with them to see the skills they have learned so far, whether it was useful or not. Next slide. So the participants were expected to attend at least 6 hours before graduating. And the curriculum is grouped into 4 classes, class 1, class 2, class 3, and class 4. And each class is expected to last for 2 hours. And this is how the curriculum was designed. Next slide. Our results. So we had 16 indigenous sexual prevention instructors trained, and they also act as influencers, community influencers. We had 180 adolescent sexual prevention cohort formed, and then we've reached 3,625 adolescents that were equipped with self-defense skills. It was also shocking to note that during this implementation with the instructors, 18 sexual survivors have disclosed for the first time of experience of sexual violence in 2020. These people have never reported or talked to anybody, but because of the safe space that was created by the instructors, they were able to disclose of experience of sexual violence. So among the 3 LGA where we piloted, we had 0 cases of rape in 2 LGA. 2 LGA recorded 0 cases of rape within the pilot phase. Next slide. So lessons learned. Like I mentioned, the AMSEFA program encouraged a positive attitude towards disclosure. The adolescents built that trust in them, and due to the safe space that was created, we had a lot of disclosure of sexual violence, which they were not able to disclose to anybody in the past. And also building confidence and skills among adolescent girls really helped in preventing violence, and helped the adolescents in goal setting and even setting of boundaries, and then equip them with the verbal skills and physical skills. A lot of them used verbal skills to avoid sexual abuse or sexual violence. Next slide. So in conclusion, sexual violence can be reduced when population at risk are empowered, which have seen among the adolescents that participated during the AMSEFA intervention. Stakeholders can challenge rape culture in communities by investing in innovation in empowering adolescents with mental, verbal, and physical skills to prevent sexual violence. When we also conducted dialogue sessions with the community leaders, they also find out that it's time for them to stand up to say no to sexual violence. Trauma management should be prioritized and integrated into programs targeted at survivors of gender-based violence to recover quickly. This was also what we noted, and it was very important. And then we also continue to form more cohorts to reach as many adolescents as possible. Thank you for listening.
Thank you so much, Charity. It was wonderful to hear about how the No Means No curricula was adapted to the Nigerian context. Maybe we'll have a couple questions before we move to our next presentation. One was from Daniel in the chat box, and just a point of clarification, Charity. Were the classes offered to the cohorts virtually or in person?
Thank you. Okay, so the classes for the session was physical. It was the training for the instructor that was done virtually, but the classes was done physical with the adolescent at the community, and it was also conducted for both for school, in school, and out of school adolescents. Thank you.
Thanks, Charity. And Daniel also wondered if the project had any information about the perpetrators of violence. And I'm also wondering if you can say a little bit more for those who disclosed violence, how they were connected with post-violence care services.
Thank you. Yes, for people who disclose of experience of violence, I remember I mentioned that instructors, they were also trained on first line support, and they also worked with community health workers that they will also take over the survivors for post-GBV referral. They were referred for post-GBV care, for health facilities, and also for police. And we also had a lot of perpetrators that stay under trial right now. They were reported to the police for prosecution, and we are also following up. We also refer them to the legal. We also partner with FIDA in our country, who also take over for the prosecution. Thank you.
Thanks, Charity. And maybe one final question from the chat box, and then we'll move to our next presentation. Stellar asked if any of the girls reported having had to defend themselves against a possible rape using the I Am Safer program, or was the reduction from the community being more aware of the problem through your dialogues?
Good question. Like I mentioned, that 6 months down the implementation, we had to go back to the community to interact with adolescents who had passed through this section to know if a lot of them had used these skills, learned over to help them to get over any issue. And then we have had a striking success stories. We have a pile-up of the success story. Even when the perpetrator is a close relation, they have also developed that assertiveness in terms of using their verbal skills to get away. Some of them has also used their physical skills to get away from these risks. It has really worked well for a lot of the girls that has concluded the safer sections, and their skills has been built. And the girls, when they were, in fact, it was so amazing that you will see that in their eyes in terms of how they are going to challenge, the perpetrators or whoever that is going to take an advantage of them by building their verbal skill. It has really worked, from the focus group discussion we've had with them, we were able to find out that, and we also going to proceed to do more robust tracer study among those that pass through the safer classes to see how many of them that use that skill to apart from the random selection we have just done while putting all these things together. Thank you. And over.
Thank you so much, Charity. That's wonderful to hear about some of your next plans with the project. Thank you so much. All right, next we will turn it over to Liawaka Mwala to speak about experiences of violence and condom use among key populations in Malawi. Over to you, Liawaka.
Okay. Hello, everyone. This is Liawaka Mwala. Thank you for the opportunity. I'll be presenting on the experience of virus and condom use among key population in Kapili area, Malawi. So the outline of my presentation is as follows. I'll look at the context, an overview of the project under which I conducted the research, GBV intervention in LEAP, research objective and methodology, key findings and insight, programmatic implications and lessons learned. Next slide. In terms of Malawi context, key population and partner account for high proportion of new HIV infection in Malawi. At the moment, HIV prevalence among FSW is 49.9% and 12.8% among MSM, 8.8% among general population. These trends may be telling us something about stigma and poor access to health services. According to DHS 2015 and to 2016, 34% of women in general population have experienced physical violence since the age of 15, and 20% have experienced sexual violence. Cases of violence are higher among key population than among general population. Next slide, please. LEAP is an abbreviation that stands for Local Endeavor for HIV Prevention and Treatment. It's a 5-year PEP and USAID funded activity that started in September 2019 and it will end in September 2024. We work with FSW, AGY, and their sexual partners. The activity builds on the success and legacy of FHI 360-led linkage project. And it's being implemented in 4 districts in Malawi, namely Lilongwe, Blantyre, Zimba, and Mangochi. LEAP aims to improve access to uptake of HIV prevention, care, and treatment services. Next slide. So we have the GBV interventions in this LEAP project. We have like 4 arms. On these 4 arms, we have GBV prevention, where we raise awareness among KPs on gender norms, GBV prevention, reporting, and response through peers. And we also conduct human rights and legal redress activities at drop-in centers. And also we are engaging bar owners to support GBV prevention in the hotspots. On the same intervention, we have a second arm, which is the reporting. Reporting, we use the peer educators, outreach workers, and healthcare workers who are trained to screen KPs for GBV. And also we use the SMS digital platform to report any cases of GBV. And the outreach workers monitor any cases of GBV in the hotspots. And on response, we respond GBV through the outreach workers, peer educators, and healthcare workers who are trained on LIFE's curriculum to provide first-line support and also to help in disclosure. And the post-GBV clinical services are offered at the drop-in centers, one-stop centers, and also the health facilities. We collaborated with legal services like CARE and partnership with the police, the victim support in particular to help us with the cases of gender-based violence. Psychosocial support and care are provided at the drop-in center. And we have a documentation part where we document the gender-based violence on the crisis management form. This is done by the outreach workers. This helps to inform the program and to improve on our service delivery. Next slide. On addressing GBV, we have a prevention whereby there's behavior communication and integration of virus and HIV risk messages. We also conduct individual, sometimes group PA counseling combined with risk reduction and virus prevention. We also have HIV testing and counseling where the HIV counselors were trained in identifying and also offer appropriate response to GBV safety planning and disclosure. They are also trained on IPV screening in index case testing services. We have like treatment also where there is comprehensive post-lab care, which includes PEP. And we have care and support where there's PA and mediated disclosure that is done. All this is done in drop-in centers, which are the safe space for key population, where all victims of GBV access post-GBV services. Next slide. In terms of research overview, as I've already said that this research happened at Kapili cluster in hotspots, which is under Area 36 drop-in center. We have 2 peer educators who support delivery of HIV and GBV prevention at community level. Research was conducted from November 2020 to March 2021. Our main objective was to investigate the experience of virus and condom use among key population. In terms of methodology, a mixed method approach was used with both qualitative and quantitative approaches. A formal consent was sought and documented to avoid social harm. HIV risk behavior assessment was included to assess condom usage in the past. Reported cases were supported with post-GBV services, and it was a sample of 100. Next slide. According to our findings, perpetrators of violence, we had like 31% clients, and we had 14 who were the gangs, and 13% were bouncers, 12% were the intimate partners, 11% were the healthcare workers and the police, 8% were the bar owners. So there is need of interventions that tackles the perpetrators of violence, including clients, healthcare workers, the police. As you know that these people are supposed to be the role models. So there's need to be special interventions that should help us so that we can lessen the GBV of this among these perpetrators. Next slide. Physical violence was the most popular type of violence that was experienced among the KP at 32%. And economic violence was 24%, sexual violence 24%, and discrimination 20%. There is need of a minimum clinical package of services to be available for those who want to use the services. Next slide. GB cases were mostly happening at the bar with lodging at 38% and 27% at rest houses, 20% in the streets, and 15% at home. There is need of peer-led GBV intervention that should be tailored to the needs of different locations and sex work typologies. Some of the interventions that were put in place were like, for those who are home-based, we're trying to have the community awareness while targeting the home base since they stay in the community. And also like those who are in the streets, we use the ICU materials so that they can have the messages, and also the hotline was provided so that they can report any cases of GBV. On those who were like the bar with lodging, we want to engage more the bar owners and the rest house owners, so that they can help us in identifying cases of gender-based violence and also manage to report the cases. Next slide. Condom usage among KPs, there was 37% who reported inconsistent condom use, and 29% reported consistent condom use, and 19% reported not suggesting condom use, 15% reported no condom use at all. It was like a total of 71% of all individuals who did not use condom consistently. So there's need of empowerment programs. Behavioral change communication on condom should be delivered to individuals experiencing the violence. Next slide. Post-GBV services are provided at the drop-in center comprehensively. 12% had STI treatment, 17% had PEP services, 15% had psychosocial counseling, 21% were referred for other services. So there is just need to increase uptake of PEP, like increasing awareness and also engaging the victim support unit so that they can timely refer the cases of gender-based violence, especially sexual, before 72 hours, so that we can increase PEP uptake, and also involving the peer educators, and so that they can help us in STI screening to refer all those who have cases of STI for treatment. Next slide. In summary of our qualitative findings, FSW felt that they were discriminated as a result of sex work. Use of force among clients of FSW was reported as a factor that led to GBV. There was negative emotional consequences that were reported by the victims of GBV, such as low self-esteem, inferiority, anger, sadness, and aggression. Severe mental health such as depression and suicidal thoughts were also reported. An experience of past sexual violence influenced one's ability to initiate condom use. One of my clients assaulted me. After telling him that without a condom, I will not have sex with him. He told me that he was already in the room and he will not live without sex. He left me. This is how one of the FSW was recounting her experience. She was so emotional and psychologically affected. I hope you can have a feel of what these people are experiencing. Next slide, please. The program is drawing the following lessons from the research. There's need of partnership with the police, paralegals, and other stakeholders to providing holistic post-GBV services for key population. Mental health interventions need to be integrated in HIV programming for KP. Use of GBV screening tools actively at clinic and community level helps identify cases that would potentially be not reported. Capacity building for peer carers on GBV prevention, response, and reporting is critical, as they most likely encounter cases through their work. Job aids, SOPs, and monitoring tools should be in place to ensure quality of intervention and data. Healthcare workers need to be trained to provide first-line support, which is lives. That's what I had in my presentation. Thank you.
Thank you so much, Leah Waka, for sharing that important work. Before we move to our last presentation, there were a couple of questions in the chat box, so I wanted to make sure we clarify a couple things. The first was just if you could clarify if the KP in the research refers mostly to sex workers only or other kinds of KP. And there was also a question about whether the peer educators have a level of clinical training or if they get support from trained clinicians. You mentioned peer educators screening for STIs, and it would also be great to hear if you have any insight into other capacity building that these peer educators might need, and also how they're trained or otherwise supported to take care of themselves, recognizing that this is very challenging work to be doing.
Okay, thank you. The peer educators, they have support from the trained clinicians that they help them to do this STI screening. We have a tool that they use normally whenever, maybe for example, they will be asking about how they are feeling, if they in the past few days they had like pain whilst in conducting the sexual intercourse, any kind of discharge that is not of normal. So if the therapists are said anything like yes, they refer to the DSC so that they can meet the clinicians. Yes. On a live training, it was virtual, but as a program, we are planning that we should have a physical one. Yes.
Thank you so much, Leah Waka. That's great to know. So it sounds like also raising awareness about services that are available and helping connect FSW with some of those other clinical services. I see that there was also a question about whether or not there are economic empowerment interventions that you might do with some of these FSWs and AGYW.
Meantime, we don't have any economic empowerment, but maybe in future, but meantime, we don't have any economic empowerment. Yeah, we're just providing the services and helping them how to deal with the gender-based virus cases.
Okay, thanks, Leah Waka. Yes, that's a great question, Emily. I'm wondering, some of you and your organizations might be doing some of these kinds of economic empowerment interventions, so it'd be great if you all can share some of that work in the chat for us to learn more about. There's also two last questions, Leah Waka. One is whether or not you're reporting on Gen GBV, which just as a reminder for everyone is our PEPFAR-MER indicator that we have on gender-based violence. It's a clinical indicator for those who seek services for either physical and emotional violence or sexual violence post-care services. And then there's also a question if you have experience working with the legal department and responding to some of these GBV cases.
Thank you. In my presentation, I narrated that we collaborated with CREA. It's a legal organization that is helping us to do with the cases of gender-based violence. They don't charge anything, it's for free. Yes. And for gender-based violence cases, yes, we are responding to them both at drop-in center level or even at the community. We are responding to general as well.
Thank you so much, Leah Waka. I see some more questions coming in, and hopefully we'll have time to get back to those at the end. Right now, I'm going to move to our final presentation from Beatrice Abura on gender-based violence and uptake of PEP among residents of Busia County. Over to you.
Thank you, Ellen, for that introduction. Then, as far as my topic is concerned, by definition, sexual violence is defined as any sexual act or attempt to obtain a sexual act or unwanted sexual comments or advances or acts to traffic or otherwise directed against a person's sexuality using coercion by any persons regardless. So PEP or post-exposure prophylaxis is a short course of HIV medicine taken very soon after a possible exposure to HIV to prevent the virus from taking hold of the body. And it must be taken within 72 hours, that is 3 days, after possible exposure to HIV, or if it's taken thereafter, it might not work. Next, please. So my problem statement was as follows. Despite the lack of data on PEP in sexual exposure or some other sorts of assaults, PEP should be offered to all sexual assault victims once the clinician have assessed all the factors involved in the likelihood of HIV transmission. And PEP should be viewed in the overall context of the physical and psychosocial trauma of the rape victims. PEP might help the victim gain a sense of control and decrease the anxiety about acquiring HIV, and should be reassured that the risk of the transmission is reduced and may increase if certain risk factors, and PEP may also be indicated in case that those risk factors have been outlined. Next. So the objectives of my research was as follows. I wanted to determine the uptake of PEP and completions after sexual or gender-based violence in Busia County. I also wanted to determine the incidences of GBV among various gender that are living in Busia County. And I also wanted to assess barriers to post-exposure prophylaxis and the completion after a case of rape. And I also wanted to evaluate why most of the clients were underutilizing PEP after a case of an assault. Thank you. Next. So the literature review was as follows. Sexual assault is a widespread human rights problem with potentially devastating health consequences. Persons who have been assaulted may experience some sort of depression, post-traumatic trauma, suicidal tendencies, and even substance abuse problems. We also have issues with eating disorders and gynecological problems that affect adolescents and young girls, and some genital injuries, as well as sexually transmitted infections. So next, continuation as far as that is concerned. So we decided to do particular characterization of sexual assaults, and this may increase the likelihood of transmission of HIV, especially those involving multiple assailants, perpetration of multiple sex acts and including anal perpetrations, and this results into injuries to the mucous membrane and the presence of pre-existing STIs. And research has also shown that sexual assault survivors are often afraid of contracting HIV infection, and thus they want access to appropriate antiretroviral therapies, as far as Janice Beaumont 2011 is concerned. Continue. So the methodology and the results of the study was as follows. We did a retrospective data entry where we collected data that was describing social demographic characteristics and the nature of sexual assaults that were done, the HIV serostatus of the individuals that were there, and aspects of PEP care cascade, because it's part of the clinical cascade as far as GBV is concerned. So we reported a total of 2,445 cases of SDPV during that reporting period of January 2020 to June 2021. Out of these cases, 3,566 were physical assaults. That was making these total cases now to be 6,011. Female survivors, as far as this was concerned, was 4,777, which was 79%. The median age of the assaulted persons was 21, interquartile range of 14 to 28 years. 1,234, that is 21%, were male out of the total number of cases that have displayed above. Then 70% were vaginal assaults, while 30% were anal cases. Next slide. Most perpetrators were unknown to the clans that were assaulted. So out of the 6,111 clans, 1,382, that is 23%, were unknown. But all assaulted persons were offered HIV testing, and 670, that is 11%, were reported within 72 hours and were offered HIV tests. And this was making them to be eligible for PEP. Then out of that, 11%, that is 21% of the 52 clans completed PEP. Then 52 clans seroconverted to HIV, that is after completion of the PEP. And there were factors that were resulting into that. Next. So now a graphical presentation of the cases as I've explained above. Out of the total number of GBV cases that were reported, 59% were physical and emotional violence, while 41% were SGBV cases. Next. Then now in terms of gender segregation, most of the GBV cases are affecting female, which is 79%, and then 21% is male gender. Next. Then now, in terms of types of assaults that the clients were presenting with, about 70% were vaginal assaults, which was 1,711. Then 30% were penile assault. That was affecting the other gender of the male clans. Next. Then in terms of whether the perpetrators were known to the survivors, we analyzed and find out that 77% of the perpetrators were known to the survivors, while 23% were unknown. So this clearly indicates that most of the perpetrators that are bringing these issues of gender-based violence are well known to the clients that experience this sort of violence. Next. So now, in terms of what was making some sorts of interest as far as the presentation is concerned, we realized that most of our clients were not reporting to the clinic within 72 hours. So out of the total number of GBV cases that are represented above, 670 clients reported within 72 hours. Then out of the 670 clients that reported, all of them were offered HIV tests because they reported within 72 hours. Then 670 tested HIV negative. Then that is making them to be eligible for PEP. Then out of the ones that were eligible for PEP, 670 were initiated on PEP. Then now we had a further analysis just to have a further interest as far as PEP completion was concerned. So we initiated a total of 670 clients into PEP, but only 52 clients completed PEP. Then out of the 52 clients that completed PEP, 11 seroconverted, that is after 1 month. Next slide. Then now in terms of gender, when we segregated further, the types of GBV cases that clients were presenting with. Now the yellow bar is for female and the blue bar is representing the male. So 2,399 clients are female survivors and 46 are male survivors. Then out of the 46 male survivors, 27 were offered PEP, while 647 female survivors were given PEP. Now, in terms of physical and emotional violence, because we have two categories, different categories, we categorize GBV separately, and then we categorize emotional and physical violence separately. So we had a total of 2,378 female and a total of 11 1,188 male that were presenting with emotional and physical violence. Now, when we segregated further to find out that out of these, how many were completing PEP? So out of this number, so we tried to lump sumly now analyze in terms of PEP completion. So we find a total of 31 completing PEP, that is female males, and 21 females completing PEP within the review period. Next. Now, conclusion as far as the analysis was concerned, so you find out that PEP was only initiated in about 670 clans among the clans that were having SGBV cases, and 820, which is 23% of the 3,566 GBV cases. So the clinical care cascade shows that late presentation into the facility, the health system gaps as far as healthcare system is concerned, ignorance and socioeconomic factors, and poor adherence to clinical cascade were the greatest culprit as far as PEP provision and completion was concerned. The earlier presentation of these clans into the facility should be promoted among sexual assaults in areas of high prevalence rates of HIV. Next. Thank you.
Thank you so much, Beatrice, for highlighting this important work in Kenya. I think we'll do a couple of questions that have come in from the chat box for you about PEP completion. One of the questions is about reasons for low completion of PEP, and among those who did not complete PEP, if you might know how many seroconverted. I think that, you know, as we also heard from Leah Waka, that there is a small proportion who present within the 72-hour window of eligibility for PEP. So I'm curious if there are any steps you plan to take to address this gap, and if you can give a little more context about what might lead to some of these delays.
You find most of the clients are reporting to the facility led for PEP uptake because of lack of knowledge. You find most of the clients are having some level of ignorance as far as provision of GBV services are concerned. And you also find most of the perpetrators are threatening the survivors. Then as far as health system is concerned, there should be integration between facility and community, so that capacity building should start from the grassroots, such that when the community are aware that these services are available in the facility and they are actually offered free of charge. But you find that most often it is the police or the administrative aspect of the government that gets to realize this through the chief. Then they now narrow down to the community level to get to know this client, that the survivor. Then that's when these cases are being reported to the facility. So this is one of the reasons as to why we are having that led presentation in the facility. So what we've planned to do, maybe that we will analyze further and maybe present later, is to have that sort of interface between the administrative aspect of the government and the health aspect of the government, so that we work in collaboration to make sure that in case these cases are identified in the facility, then they are reported within 72 hours. Then we've also planned to do capacity building from the community level using community health workers and the opinion leaders, just to create an awareness to the community that if in any case there is that sort of violence in the community, then the client needs to present within the facility within 72 hours for them to benefit on the available resources as far as the clinical cascade is concerned, to prevent them from seroconverting at the end of the completion of PEP. Thank you.
Thanks, Beatrice. And there's a couple related questions about whether or not there are peers, for example, supporting completion of PEP for individuals, and if you have any PEP case management efforts.
Thank you, Ellen, for that question. We have, but this one is not like comprehensively being done. But as we were analyzing our data, we realized that as a clinical care, we might also be failing. So as we are speaking right now, after I had presented this to our office, then we decided to develop some PEP champions within the facility level that are phone call away with a hotline that can be called, such that if in any case there is a case that needs to be presented to the facility, they are brought on board immediately. And we had also planned to start some sort of school health programs. Previously, we used to do them, but due to COVID-19 pandemic, we slowed them down because of issues of not converging and the social distance aspect. So we've decided to revamp these aspects just to improve on how soon these plans can present themselves to the facility for these services to be offered in time.
Thank you so much, Patrice. I'm curious if you can say a little bit more about the school health efforts and what kind of education or awareness raising you do there. But it's great to hear that you all are talking about also having some PEP champions. And I'm curious if other partners who are on the webinar right now already have these in place and want to share anything about their experience with that in the chat box. That would be great.
Thank you.
One last question for you, Patrice. I think several folks noted that it looks like there were a significant uptake of PEP and completion among men. So I'm curious if you all have any insights as to why that might be, and to know if there are other efforts that you all are undertaking to engage men in helping to prevent GBV.
Thanks for that question. You find from the beginning of the presentation, most of the perpetrators are men. We have very few survivors that are men. But now, as we were analyzing our data further, we found out that when it comes to completion of PEP, men had a higher percentage than the female gender. We didn't have an insight as far as this is concerned, but we've developed some questionnaires that we now want to give out to the survivors that will be presenting to the facility, just to have a further insight as to why there is this disparity, such that when such a question is asked, we can have a source as to why there is that difference in terms of men completing rather than the females. Yeah.
Thank you so much, Patrice. Now I had a question to open up to all of the presenters. I think this is something that we've heard about across all of the sessions, since it's such a key factor impacting all of our work and lives right now, and that is about the COVID-19 pandemic. I know that all of your projects took place during that time frame, so I'm curious if there's anything else that you wanted to add about how COVID-19 might have impacted either how you interpret your findings from your work or how you might be changing your plans for implementation to address some of your findings. So maybe, Charity, we can go back and start with you for that question.
Thank you, Erin. For me, COVID-19 really affected the AmSafer project right from the training of the instructors. It was basically because of the COVID-19 that the training was done virtually. And when you look at the number of adolescents we reached so far with AmSafer curriculum, the number is a bit low compared to what we planned. We had in plan to have at least 40 participants per cohort, but due to the COVID-19, we limit the sizes of the cohort to 25 to ensure that they maintain social distancing. There are a lot of things that at some point, when the COVID-19, at the peak of the COVID-19, we are not even facilitating cohorts, at the peak of the COVID-19. So it really affected the number of adolescents we plan to reach during the implementation cycle. Thank you. Over.
Thank you so much, Charity. Liawaka, over to you.
Hello, thank you. COVID-19 really had an impact on our activity. We used to first have like a group discussion, like the focus group discussion on a large scale, but due to the COVID-19, we could narrow it down to one-to-one sessions or a small group. Yes.
Thank you so much. And Beatrice, do you have anything to add about how COVID-19 might be impacting your work and making it more or less likely, for example, for survivors to be presenting within that 72-hour window?
Well, I can give response in relation to where I'm currently working. I'm working in Busia County, and Busia County is bordering Kenya and Uganda. So you find that during this period of COVID-19, we were having so many cases of SGBV, and then we had a total lockdown between the two bilateral countries. And in Busia, we are serving clients from both sides of the border. So it was difficult for the survivors to come to the facility. And it was also affecting the other clinical cascade as far as HIV is concerned. Yeah. However, we developed a strategy that was helping us because I'm also supporting care and treatment. So we developed a strategy that was helping us to follow up both aspects of survivors, both for HIV and GBV, by working with the health management team from both sides of the border to support. I can't explain further because of time constraint. Yeah.
Thank you so much, Beatrice. I think we've addressed many of the questions in the Q&A and chat box, but I encourage you all to continue adding as we have about 10 minutes left, so some time for additional questions. I saw that we had a question from Olympia about your experience with lives or provision of first-line support and HIV programming among the general population. I think that you all touched briefly on some of the lives training that you've done among your peer educators or your clinicians, but I wondered if anybody had anything else that you wanted to say about your experience with provision of first-line support in your projects. And while you all perhaps mull that one over, it looks like we also had a question about classifications of assault. And I believe that this one was for Beatrice. And it was talking about the difference between vaginal or penile and mentioning that the PEPFAR classifications are different. And I think that that's speaking again to our Gen GBV MER indicator. So wondered if there was anything that you wanted to add on that, Beatrice.
Well, in terms of classification, we based on where we are, we just decided to add additional indicators because we were having so many cases of key population clans that were coming to the facility with SGBV. So out of interest and curiosity, we just decided to add another column into the GBV register just to further categorize the type of assault that these clans were coming with, because that would help us in policy making to get to understand what best can we do to prevent this, and even collaborate with the key population partner to support on how best this can be tackled. I know it's not part of the PEPFAR indicators, but we just added it to help us in policy as a country. Thank you.
Thanks so much. And maybe while I have you, Beatrice, I think there were a few questions as well. If you had any information on age disaggregation for your presentation and research on PEP, and whether or not age might also be a factor in who is presenting within that 72-hour window and who might be completing their course of PEP.
When we were doing conclusion, we further categorized in terms of gender, and the survivors, I think it's on the 4th slide, where we have the age segregation as far as survivors is concerned.
Thanks so much, Beatrice. I wanted to add one thing, that practicing self-care is incredibly important when doing this work. It makes us all more available to others around us who might need emotional support, including our colleagues and clients who are experiencing or have experienced violence. Self-care is so important, especially in the work that we do in PEPFAR and when we're responding to GBV. If folks are comfortable doing so, please add in the chat box one activity that you did either in the last week to practice self-care or that you might do today after this webinar. I'll give one for myself. I love taking walks, especially since we're enjoying some fall weather here in Washington, D.C. So I plan to do that later after these wonderful presentations that we've had today. Oh, great. Playing with the dog. That's a good one. Exercise is popular. Great. Yoga. Oh, and Charity already exercised today. Well done. Listening to music, walking, great. Oh, I see somebody's doing a plug for the 30 days of gratitude. Let's see, there's a question from Olympia about whether PEPFAR can organize another lives training for partners. So excellent question. We're so pleased to see all of the interest in lives, recognizing that this provision of first line support is really one of the most critical things that we can do to support survivors and our staff in the program. So I think that that's something that our team can discuss, and that you can also reach out to your mission colleagues, your mission gender point of contact for USAID about options for lives training and support. We can put in the chat box some of the WHO training resources and materials that are also available for doing lives training for local partners. I don't know, Beatrice, Leah Walker, or Charity, if any of you would like to share a bit about your experience in providing lives training for your partners and staff.
Okay, thank you, Erin. Let me just share my experience on providing the first line support. Last year, we all participated in the live training that was organized by USAID, and all my organization staff, all my staff, were also in attendance. And after that training, we cascaded the training to the community case workers. And shortly, after the training, there was an increase in GBV identification, early identification in terms of asking for experience of violence using the screening tool that we developed. It really helps in identifying more people that have been experiencing sexual violence, and even how they manage the survivors when they disclose was also, a remarkable improvement that we also observed in our program. It really helped, and we are also looking forward for more training for new hires that join us since the last year. Thank you, and over.
Thank you so much, Charity. Leah Walker, would you like to add?
Yes, as a project, we adopted lives training guidance. In terms of adopting this, everyone who reports IPV is offered lives, and we also adopted tools of PEPFAR like adverse event reporting form, adverse event investigation form. We designed also an SOP and job aid for adverse event monitoring. At the moment, in terms of indexed investigation, there's a concept where one sign or use a thumb when they have accepted index. Everyone, we have offered index test services. When they come for a subsequent visit, we actively scan for adverse event following her acceptance to take part in the index testing. So far, that's what we have adopted from lives training.
Thank you so much, Liawaka. Patrice, do you have anything you'd like to add about your project?
Thank you. My project also participated in the lives training that was organized by PEPFAR. We've rolled down the same to the various facilities and the sub-counties within the county. And we are also implementing assisted partner notification services that is called APNS. So we had to lay down strategies and change some policies as far as provision of that service is concerned, because we know APNS has some connection with intimate partner violence. So before clients are done assisted partner notification services, they sign a consent form that will protect them in case of an IPV. Then we also tried now to diversify screening at various points, just to make sure that we are in a position to capture these clients and give them support timely. Thank you.
Thanks so much, Patrice. And Emily's just put some of the lives training materials into the chat box. And again, we really appreciate all the work that you all do in this very critical area to support survivors of violence and to help end the HIV epidemic. Huge thanks to you, Patrice, Liawaka, and Charity for your presentations today. This has been a really excellent session, and we appreciate all of the participation from those of you who joined and your questions. So I believe that these materials and the video will be posted. Please don't hesitate to reach out to us or to your mission POCs about any questions that you all might have. Thank you so much and have a good day. Please take care of yourselves and implement some of the self-care suggestions that we heard in the chat box today. Thank you all so much.